for your final version. I'm never gonna give up, fall down, I just gotta.
You're listening to the Tom Ficklin Show on WNHLP 103.5 FM, your home for community radio.
Good morning, everyone. And wherever you might be on the planet, this is an important show. Actually, all of our shows, in my mind, are important. But if you don't love what you're doing, then you should not be in the business. We've been broadcasting since 2015, and I got to say, with WNHH 103.5, which is really an outgrowth of the vision of Paul Bass to secure the federal communications license, low power license. It's been a true joy to kind of be involved from a community research, community standpoint perspective. And I say community research, community standpoint, because information is sometimes researchable. It's verifiable, but it's also, you can use that information for your further research and further collective kind of discipline and collective solutions. We're going to talk about collective solutions today, but also there's always a need for leaders and folks that could kind of shed light on the path and participate in the path. Dr. Emma Lowe is here today. She describes something called street psychiatry. Street psychiatry as a power flip. We hear this phrase, flip the script, and I really love when this was kind of suggested to me, because Dr. Lowe is really involved with how can mental health services meet people where they are instead of requiring them to go where the so-called professionals are. And I don't mean to disparage professionals by saying so-called, but how can we really rub shoulders with people and not have barriers to kind of interfere? So it's a community-based approach and designed specifically today. We're going to talk about for people experiencing homelessness, reach of street psychiatry. On today's show, Dr. Lowe will discuss her work, and it's really just a pleasure to have her with us. Her work and her research in health services, not only health services implementation, but healthcare access for vulnerable populations. And I guess got to say that whether you might think that you're not vulnerable today, all of us are vulnerable in some ways, and can be even more vulnerable as the economic system engages you. So Dr. Emma Lowe is here. She's at the Yale School of Medicine, assistant professor of psychiatry, medical director of the street psychiatry team, co-director of public psychiatry track, clinical faculty, et cetera, et cetera, et cetera. She's a good person. Let me just say it like that. Also, we're really blessed to have Reverend Dr. Leroy O. Perrier with us, pastor of St. Stephen's AME Zion Church, and cultural ambassador to the Yale Clinical Research Program. Reverend Elvin Clayton is also with us, pastor of Walters Memorial AME Zion Church, and cultural ambassador to the Yale Clinical Research Program. Let's get to it. We have like 50 minutes or so, and it's really just a pleasure to kind of talk about this street psychiatry issue. Dr. Lowe, good morning.
Good morning. Thank you so much for having me.
Thank you for having the time and to share with us. And let's get right into it. Can you tell us a little bit about this concept of street psychiatry and what is the target population?
Yeah, thank you. So I think of street psychiatry as really a method of engaging people that are experiencing homelessness, and they may or may not have a serious mental illness, meaning something that's very severe, like major depression or schizophrenia or bipolar disorder or substance use disorder, and really going to where they are in the community. And like you said, not expecting them to come into the clinic. We know there are many barriers for people who are living on the street to coming in for care. There's a lot of stigma. There's a lot of vulnerability in terms of people's day-to-day life, and they're oftentimes in survival mode. They don't have the time and the energy to dedicate sometimes hours to waiting for an appointment. They might not have logistical means like a phone to remind them of the appointment or to even make the appointment in the first place. And so our model is really about taking the providers out into the community. And so we literally go out with backpacks with a multidisciplinary team to encampments, to places where people are living in the community, whether it's the green or soup kitchens or encampments throughout the city, and we provide treatment there. And I'll say that we don't just provide treatment, we offer treatment, but a lot of people are not necessarily ready for treatment. And so we make that accessible and available to people, but also understand that people are at different stages of change and different stages in their kind of recovery. And we really respect that and try to work on people's own paces and meet them where they're at, both literally and metaphorically.
Excellent, excellent. And Reverend Perry and Reverend Clayton, just before I kind of ask you for your comments, and it's really just a pleasure to kind of have you join us on these discussions. But Dr. Lowe, this sounds like, well, let me be frank, hard work, but I guess it's also hard work. I guess that there's a compassion and actually even degree of love involved. Just, if I can get a little bit personal, how did you even develop a passion for this, for folks that have been often neglected?
Yeah, so I think it started for me back in college. I went to a small school, Haverford College outside Philadelphia. And I was thinking about medical school at the time, but wasn't sure I was going to necessarily go to medical school or specialize in psychiatry. Certainly at that point, I was doing some work with people on the streets of Philadelphia, just doing like volunteer work. And I decided to major in fine arts. And my thesis project was painting portraits of people who are living on the streets in Philadelphia and trying to humanize them and put a face to homelessness in that way. And I just really loved that project and was able to kind of build these very colorful, kind of humanizing portraits of people and represent their character and as well as some of their suffering and stories. And that was where it all started, I think. And then sort of towards the end of college, I found out about a street medicine program in Pittsburgh, which was run by Dr. Jim Withers, who happened to go to Haverford and did a talk at Haverford while I was there. And I was just so enthralled and inspired and was able to shadow him for a few weeks over my winter and spring breaks, and then over the summer. And then found a job there doing as an AmeriCorps volunteer and was able to work with their program for the following year, which is where I feel like that was like a formative transforming experience for me, where I was under his mentorship and learning about street medicine, meaning like the sort of general term for all the medical care that is provided to people who are living on the streets, who are out under the bridges, and making that care accessible for everyone. And then so I learned about that model there, and also was really was able to work with individuals sort of on a more informal basis, doing their case management, kind of helping them go to their medical appointments, helping them get services, and was really I really loved working with the people with really severe mental illnesses, and they're often the people that other people had a hard time working with, and I just found them to be the most interesting, and I had the most compassion for these people. Sometimes they had serious mental health issues. Sometimes they had serious substance use disorders and medical issues co-occurring. But it was just felt like my calling that I was working with these folks, and just really enjoyed working with them, and really just was interested in learning more about them and their stories. And just every person was unique and always kind of threw me a challenge every day in different ways. And then I took that with me through medical school, where I went to the University of Rochester, and some students and I started a street medicine outreach program there, just doing kind of basic work, like helping people and who are on the streets there to get access to medical care. And only later did I discover that I was meant to be a psychiatrist, and did my psychiatry rotation in the very last thing of medical school, and was like, oh, this is where I'm meant to be, and these are my people, and realized that all this time, all the people that I was working with were suffering from serious mental illnesses and addictions, and that was kind of where I realized all these things matched and fit together for me, and was kind of where I belonged. And I really can't imagine practicing psychiatry any other way. It just feels like the most, for me at least, like the truest kind of form of practicing medicine is really being of service to the people and being out there with them and accompanying them. So that's
Tremendous.
a little bit of my background.
Well, I mean, it might be a little bit, but it's really so substantive. And we have a lot of young people that listen to this show. And so I really appreciate your sharing your transformation and your transitions from career and college and contacts and mentorship, for people to see that if you keep your eye on the prize, so to speak, although the prize might not be that clear, you can still kind of follow your instincts. And I love when you mentioned the word calling. That's so profound. Just before I go to Reverend Perry and Reverend Clayton, Dr. Law, I wanted to kind of just share with people and have you remind folks that whether we're talking about the New Haven Green or Tent City here in New Haven, or Calcutta, India, or Uganda, where you've practiced as well. This homelessness issue is a global concern. Would you like to kind of talk about how that informs your perspective and your practice?
Sure. Yeah, I've been really lucky to be able to travel and do some work abroad, and specifically in between my work in Pittsburgh and medical school, I went to Kolkata, India, where I shadowed a street medicine program there that's run by Dr. Jack Prager, who's now actually retired, but he's a fantastic physician whose mission was to provide medical care to those who are living in the slums and on the streets in Kolkata, which, as you can imagine, that's hundreds of thousands of people. And so I was witnessing that in a very direct way, and seeing how he was able to offer medical care for people that had, these diseases that we don't even see in the United States anymore, because of the, advances in medical care that we take for granted sometimes, and seeing people get, TB medications for drug-resistant TB, where we don't usually see that here. Or having treatments for children with vitamin D deficiencies and other nutritional deficiencies that we rarely see. And just the vastness of seeing that model of trying to deliver medical care for that vast of a population. And that was really, really interesting for me to see, and kind of just really how his mission transcended everything. And even though it was extremely difficult, and there were a lot of people and all these systems that you can't really change, because it's he wasn't part of the government or part of the health system formally, and it was a nonprofit NGO organization. And but seeing how he still persevered in trying to deliver care for people that didn't have access to it otherwise, was very inspiring. And then during medical school, I went to Uganda, to rural Uganda, through a program through the Albert Einstein School of Medicine, run by Jerry Pascione. And this was a program that medical students would go and help the village health worker program run, which it's not really formally called street medicine, but I see it as a related model, where people who are village health workers are trained. Usually they are women that have sort of a middle school or so education level, and are working, have really good relationships with their community, and can be trained in basic healthcare, especially preventative healthcare and primary care, and chronic disease management, to help deliver basic care in their communities where there is no other option for healthcare. The hospital is hours away. And so we were working on that project there. And I think that kind of helped me understand street medicine in a sort of rural application, because it's still the same idea of going to people and empowering those. But yeah, I guess what was really great about that program was really the empowerment of the village health workers themselves. And I think that model could be used even more in street medicine. We sometimes employ peer outreach workers, which I think is super, super important, to provide some of the services and do the outreach to engage people that are difficult to engage, just, by having someone that's been there, that's in the, been homeless or been suffering from addiction in the past, can really relate to them in a different way. And so I think seeing that in place in Uganda kind of helped me believe in that model of people being able to help their own communities and being empowered in that way. So
excellent. We're going to take the deep dive in terms of your New Haven involvement, because you serve as the medical director for the street psychiatry program, which works primarily here in the state of New Haven. But Reverend Perry and Reverend Clayton, I just want to kind of weave you in, and always good to see you gentlemen. But it seems to me, Reverends, that often this society kind of dismisses folks and forgets about people, and you may even see them on the street, but you may not really even see them on the street. And sometimes we even are challenged about what we can do to help. But I guess wondered what your thoughts were about the street psychiatry and street medicine program, and what is some of its benefits and challenges might be. Reverend Perry?
Yes, Tom, thank you. And Dr. Lowe, it's good to see you again. As you were talking, I realized that that my dissertation was on homelessness in New York City during the Dinkins administration. So my dissertation was entitled Hospitality, a Theological Approach to Homelessness. So we worked with the Fort Washington Armory, where there were 800 men, mostly minority, African American and Hispanic, who every day this was their life. And David Dinkins had really, I mean, as a mayor, people don't give him the credit that he deserves, but he really tried to make a difference here.
Mm-hmm.
And he tried to make for just implement programs that would reach out to homeless people, put them in places where they would be safe, make sure they had food. And so in the interviews that I had with many of these homeless men, I think there was this innate suspicion that the government had either mistreated them and they were mistrustful of it. And so they just did not want to participate. And they would rather do nothing than to even get involved. So what we were trying to do with the churches we were trying to have our members go in and help them write letters, encourage them to, get involved in employment, to reach out to their families if they wanted this contact to continue. We served meals for them so that they can be in a community where it didn't look like they were estranged, but that there were people there who cared about them. I haven't seen any programs like that, but I do think that the street ministry is a program that very much so mirrors that kind of caring. And you don't find that everywhere. When I was in Torrington, I worked in an agency a New Opportunities agency, where I had young white kids who had left home and they were living under the bridge, and they weren't alone. They were living in the woods. I kind of thought it was exciting in a way that people would dare to do that. I'm asking, what did you do for your food? We hung it up on wires so that the bears wouldn't get it. I said, the bears? Why would you not want to be home? Well, my dad beats my mom. They're on heroin, and we just wanted to get away from there. So they came in looking for vouchers to see if we could help them. New Haven in larger cities is more of a crisis, it seems to me. And I think what makes it even worse is the addiction and the mental health issues that accompany it. So I mean, it's a broad problem. I don't know. I don't really see any major solutions. I think all we can do is to do the best we can to help. And Dr. Lowe, one of the things that always bothered me was that people who have mental illness, you just can't put a Band-Aid over it. It's like, sometimes it takes years to treat these conditions. And like you say, getting them to be concerned about their own condition is a monumental task, to take charge of their health. And I don't know if the missing ingredient is God, I'm just saying, or family, or a sense of self-care or self-respect or self-esteem. But there are some missing elements, and I think that we have to continue to struggle to figure out what those missing components are in our effort to help the homeless.
Indeed. And Reverend Clayton?
Thank you, Tom. And Dr. Lowe, it's such a joy to hear you today. This is a deep subject. In today's economy, with the cost of housing, the cost of food, transportation or lack thereof, cell phones, people may have a phone, but they don't have minutes to do the thing that they need to do. And Tom's question, that some people may dismiss what's going on. Some people don't have a clue what's going on. And these people who are homeless and have lack in so many areas, I don't know if people don't want to help, they don't know how to help. That you send them to agencies and there's a backlog, there's a lack of employees there, and we discovered that you're making many phone calls, you're writing letters, and it's just a slow process. But when a person has a need and the needs are not met, if they didn't have a psychiatric problem, they may have it after that. So the need of your work, your ministry, it's vital to the society to help in this area to get people from one place to the other. We got so much going on. We're praying for people. We're talking to people, but we also need the medicine piece and the tangible piece. We need it all.
Dr. Lowe,
Dr. Lowe, excuse me, Tom. Dr. Lowe, I have a question for you in terms of the male and female homeless. It just seems like dealing with female homelessness is different than dealing with male homelessness. Do you find that in what you do, and how do you work with that in terms of how do you help them, the men against the or over against the women?
Well, Reverend Perry and Dr. Lowe, maybe in conjunction with that, this might give Dr. Lowe the opportunity to talk about as a medical director for street psychiatry, that's working here in the city of New Haven. Maybe she can incorporate the answer to your question in terms of what her team does, so people can get an overall scope of your comprehensive intervention. So Dr. Lowe, tell us a little about your team and the overall work that is done at the Connecticut Mental Health Center. And then if there are those differences between, are there, sexual male-female issues that need to be addressed?
Yeah, for sure. Thanks so much for those questions. And yeah, I'd love to address that. I guess just to give a broad overview of what we do, we're based out of the Connecticut Mental Health Center, and I just have great thanks and admiration for the Department of Mental Health and Addictions, who has provided funding for this program since 2019. And so we're a state-run, originally agency, and in conjunction with Yale, but we basically provide what we would provide at CMHC, which is, your traditional mental health evaluation, your crisis evaluation, ongoing mental health medication management, ongoing therapy. But we move that out into the community. So we bring all of our releases of information and our intake paperwork, and we all of our staff, like for our team, which is me as a psychiatrist, or our other psychiatrist, Dr. Fabiola Arbello Cruz, our clinical social worker, Eileen Hamill, and our program manager, James Adu. And we have outreach workers through multiple agencies as well that work with us. And we go out to the encampments and the green, soup kitchens, various areas in New Haven, and really try to engage with people. And we may not be doing that evaluation right on the spot. We have the ability to do that, but sometimes it takes months or even years before we get to that point where someone's ready to accept mental health treatment. And so we're kind of doing all these constant, like, small evaluations where we're just saying hello to people, offering them basic needs items like socks and food, and trying to build trust and relationship with them. And just thinking about what you were saying, Reverend Perry, about like the trust and the lack of trust that people have in the system. We find that so often that people don't trust the housing system, they don't trust the mental health system, the medical system. They've been mistreated many times, and it's very difficult to kind of overcome that barrier in terms of building the relationship with these people. And sometimes it's like I said, months to years before we get any ground. And so the way that we kind of try to make progress is just really respecting people and engaging them on their terms, whether it's like they say, I don't want to talk to you today. And we're like, okay, that's fine. Like, we're not going to talk to you. We want to respect your space and your privacy. We're going into people's homes, and even if they're experiencing homelessness, it's their space, and they have very little, oftentimes, material possessions, and their privacy and their space and their dignity is what they have. So we really try to be very respectful of that, and ask people if we can return to talk to them again, ask people, permission to bring someone else in the team to come visit them. Really, really listening and really seeing what the needs are. Sometimes it's like, I really need an ID. That's the most important thing to me. Then I can get a job, and then I can start working, and then I can get out of this cycle. And if that's the priority, that's what we're going to work on. We're not going to push like, oh, you should get your mental health treated. Like that's not the person's priority. So that's not our priority. We really try to be very person-centered with our approach. And we do see a lot of differences with men and women. There are definitely more, like statistically more men experiencing homelessness than women overall. But I think that it's actually probably women may be undercounted because of like women homelessness tends to be people that are doubled up or doing unfortunately doing like sex work and other things that are just necessary for their survival to get shelter in return. And so those that not necessarily every woman who's experiencing homelessness has to practice sex work, but we see that is a big population that is often missed in terms of counting people who are experiencing homelessness. And it's also a group that's very mistrustful of the system. They don't want to be found out, and they don't want to, they don't often even qualify for services because they aren't considered by the definition of homelessness to be officially homeless because they're not outdoors the majority of the time. And so they don't even qualify for housing services often. And so those groups, we find it to be important to reach them through different ways. So one organization we partner with is SWAN, the Sex Workers and Allies Network, and they have a really good finger on the pulse of the sex work community and making sure that we are able to access the women in need. And we've done therapy groups for them in the past because we found that individually on the street, they were feeling very vulnerable, wouldn't want to talk to us, would be very closed off, guarded. They didn't know how to trust us. And but a different approach was to have a group in the community. So we would have like a therapy group organized by SWAN and have myself and our therapist lead a group with women, and they could come on their terms and leave if they wanted to and share whatever they wanted. But it was more like a private space that they would have the opportunity to share with one another some of their traumas and difficulties. And that's the other thing that's, I think, common to both men and women, but certainly women who've experienced homelessness. There's extremely high rates of trauma from both their childhood trauma and then ongoing trauma, and people are very likely to be victimized on the streets, unfortunately. So there's a little bit of that different flavor in terms of vulnerability when addressing homelessness among women versus men. So I hope that helps answer your question.
Oh, yeah.
I can see your thought process is moving there, Reverend Perry, after seeing you a few times on the shows.
Yeah. Clayton, you got your hand up?
Yeah, I do have a question for Dr. Lowe.
Perfect.
Dr. Lowe, can you talk about the levels of homelessness? Because you mentioned something about in home part-time or something of the sort. Can you share that with us and the listeners?
Can you say that? I'm not sure exactly what you meant.
I think he's asking for a definition of homelessness.
Exactly.
Yeah. Sure. Yeah. So I would say, I'm not going to say this perfectly, but the HUD, like the Housing and Urban Development definition, which is what is often used for benefits for housing, is that you have to be like sleeping in a place that's not traditionally habitated by humans, like a car or outdoors or an abandoned building. And specifically, they often define homelessness in terms of time. And so chronic homelessness is different from sort of transitional homelessness. And usually there's more resources for people with chronic homelessness because it's a group that's tends to have more chronic medical and mental health conditions. And sometimes it's seen as, people don't, there's many thousands and thousands, 500,000 people in the United States are experiencing homelessness on a given day. And they have to kind of triage and prioritize some way. So they prioritize chronic homelessness, which means you're homeless for a year or more, or have, I think, at least 3 or 4 episodes of homelessness in a certain time. And so, but you can see that that's pretty specific, and also it doesn't include the people that it excludes, I will say, is people that live in hotels. A lot of people are living kind of paycheck to paycheck or disability check to disability check. They can afford a hotel for like a week of the month maybe, and that's clearly very expensive to be paying for a hotel as opposed to an apartment, but sometimes they don't have quite enough money to get an apartment. They need a security deposit and that kind of thing, and they can afford $75 for this one hotel room, for the night. So that's where their mind is, to like survive and just get a shower, be warm for that night. So it excludes anyone in a hotel or motel because that doesn't count as uninhabitable. It excludes people that are doing sex work that are doubled up, for example, in like someone else's house. If you don't have a place to live, but you're sleeping on your friend's couch, does not qualify either. So you can see how that kind of excludes a lot of people that would otherwise be counted perhaps and given services. Those are just some examples.
And
I have
Doctor,
a
go ahead.
okay.
No, go ahead, Reverend Perry.
No, so here's one of the problems, I think, that, for example, if you have a person who becomes homeless and they have a child, and now they're afraid to go to agencies because they think that DCF is going to come in and take their child. So they're desperate to the point where they'll almost do anything, but the people that's supposed to be there to help them are the people they're afraid of most. I don't know if there's any answer to that kind of catch-22, but it just seems to be, it's a difficult problem.
Yeah, no, it's really hard because people, don't want to have that have DCF intervene upon them and break up their family, but also it is a time that's very vulnerable. You don't want to have a child living outside. Like that's not a good situation for anyone either. I do know of some family shelters through New Reach is one of the programs that does family shelters. And so they do a really good job of trying to help people in families. And so I can't say I have a lot of experience. Like I haven't really encountered like a child, like going out on outreach and finding a child just like on the street with their parent. But it would be really hard for me if I did, because it's sort of like this tension between what's best for the child and what's best for the family might be different. And you don't want to have a child living out there, but at the same time, maybe the parent is perfectly capable of caring for that child and providing them with food and sending them to school and doing, giving them clothing and doing the things that the child needs, and shouldn't be penalized for an economic situation that they've been put in, not to their own fault. So I think it's really difficult. And I think it would be like a case by case kind of thing where you really have to evaluate what's going on and what the care that's being given is, and what are the risks, and is there neglect or is there abuse going on, and just really get them into those shelter services as soon as possible.
And Dr. Lowe and Reverend Perry kind of referenced this, and you mentioned the word New Reach. What are some of the other partners that you work with? Because I want folks to kind of walk away knowing that you're, as medical director for the street psychiatry team, there's a network, and you have folks on the bench as well as folks on the field that you're coaching and working with.
Yeah, for sure. Yeah, I'm so glad you asked that. We have so many good, really wonderful partners. Cornell Scott Hill Health Center has a street medicine team that operates throughout the city. They actually helped teach us where we were going in the first couple of years, where the needs were in the community. So they're a really great resource and have a very big team that provides wonderful primary care for people experiencing homelessness in New Haven. The Columbus House is another very large agency that does primarily housing and outreach and engagement and shelter. So we work very closely with them, get a lot of referrals from them. Liberty Community Services as well. They have their own drop-in center and outreach workers and housing programs. The Desk Drop-in Center is one of the warming centers currently, but also operates during the day as a drop-in center for resources. We have some of our staff go there, as well as other agencies kind of coalesce to provide services there. I mentioned New Reach, so many other, I'm like,
are you guys aligned or functionally kind of collaborating with the Compass program? Yeah, we are. We were sort of involved in the initial stages just to provide some experience and feedback, because they as you might expect, our populations overlap, and so their founding group was in touch with us to sort of understand what
our experience was on the streets and what we might anticipate would happen in terms of when they started their program. And then once they have since launched, we've gotten a couple of referrals from them because they're not really designed to provide like ongoing treatment themselves. So they're really a team that can refer and help connect people with other programs, but they have identified patients for us to follow up with, and we have. So I think it's just a wonderful resource to have in the community, and make sure that everyone can get access to mental health treatment when they need it.
We have about 15 minutes, everyone. So just as thoughts come to your mind or issues.
Yeah,
or
I have another question.
Mhm.
So in terms of treatment, for example, when we talked to Dr. John Crystal with people with mental health illness, he said that the new drug of a superior drug of choice was ketamine, and that it was not readily available to people. And I think he was really saying marginalized people. So, you got one drug for rich people, one drug for poor people. And I think that's a problem. And then it just seems to me that for as long as I can remember, methadone was the thing that they just give people, just say, okay, so here's what we're going to give you. It's the standard now, and you can get this once a week. Your high will never get so high that you'll want to steal, kill, rob, or whatever. So we're going to give this to you. And the work that you do in the community, in the streets, do you find this whole issue about the drugs that you have to work with people? Do you feel that they are sufficient, or maybe that should be looked at again and reevaluated in terms of how we treat people? Because, like you say, you have to treat everyone for who they are, and it's not just like a mass treatment of everybody gets the same candy, the same drug, or the same treatment, because people are different. So I'm just wondering, in your work, is that one of the caveats to what you do?
Yeah, that's such a good point. And we do see that disparity going on. I guess I would say a really good example of that actually is what you mentioned with methadone. And for the treatment for opioid use disorder, as you may know, there are multiple treatments, methadone being one of the older treatments. And then there's also newer treatments like Vivitrol or naltrexone, which is an injection once a month that blocks any opioids from working. There's also Suboxone or buprenorphine, which is a strip that goes under the tongue that also reduces any cravings for opioids. And it works similarly to methadone in that it provides an opioid replacement for the body to feel satisfied by the medication. And so there's no urge to use on top of that. And both, all of these medications are actually really life-saving in preventing opioid overdoses. And we're in a huge opioid epidemic. And but you do see a disparity because there in terms of people that have access to methadone versus Suboxone, for example, it tends to be there's a racial disparity there. People who are prescribed methadone are more likely to be Black, and people who are prescribed Suboxone are more likely to be white. I think that's largely because Suboxone is newer, it's more convenient, and methadone has this kind of stigma against it. Even though it's extremely effective, but it's very highly regulated. So people have to go every day to the clinic, typically until they've kind of regained a stability in their recovery. But it's a little bit more difficult to access. You can walk in and get methadone any day, really, like with the open access programs that App Foundation has, but it can be difficult for people who are on the street because then they have to get to that program and go there every day and get administered this medication. And that can be a huge barrier. We've seen that with our clients that sort of fall out of treatment with methadone because they can't get there every single day. They've, so many transportation issues and barriers. And then with Suboxone, we actually provide Suboxone ourselves. We can't provide methadone because it's too regulated at the moment, but we can provide Suboxone to people. So that's one of our ways of kind of improving the access and addressing that disparity. So we prescribe it and sometimes even pick it up for the patient and deliver it to them. And we can even do it the same day. We've tried to kind of really prioritize that since it can be really life-saving. and making sure that disparity is a little bit less, at least, just trying to reduce any barriers that there are for people getting the life-saving treatment.
So is that an everyday that's a once a week treatment to Suboxone?
Good question. So it's every day, but it can be dispensed by a regular pharmacy. So it's kind of like any other prescription that you might get in a pill box. It's just in a slightly different format. It's like under the tongue, but it like I can prescribe it for any number of days that I want. It's either usually for a week or even up to a month at a time. And so there's much more convenience and flexibility with that kind of scheduling as opposed to methadone. So that we find that can work better for our population. It doesn't always work better, but we want to make that option accessible for people to sort of not have the barrier of having to go to the office to get it.
Is it free to them?
Yes, it's usually people that we work with are almost all on Medicaid, or Husky, which is the Connecticut Medicaid, and that covers Suboxone fully. And so usually the pharmacy won't have any copay. And if for some reason the person is not eligible for insurance because of immigration status or other issues, they can come to our clinic at CMHC for it'll be covered for them at our clinic.
Is there any plans or vision to take psychiatric street ministry to other cities in the state?
Oh, I would love that. I think hopefully we can get some of the Demas people to listen in on this. And I'd love to have that happen. I think it would be great to be able to expand this kind of method and apply it in other parts of the state. Because I really believe in it as kind of this long, slow process of helping one person at a time, but really can see the difference over time and seeing people get housing and get into recovery. And so I'd love to see that.
Dr. Lowett, maybe expand a little bit, if you would, when Reverend Perry asked, and your answer was so profound in terms of the opioid situation and the various treatments. But color for us, share with us a little bit, help us to kind of see some of the other behavioral interventions that you're involved with, and then tie that in again to access to treatment. But I'm just curious about some of the other specific services you might provide from a psychiatric standpoint.
Yeah, so I guess to be a little more specific with the interventions, so I mentioned some of the medications that we provide, but also we have a licensed therapist on our team, and it's a little different to provide therapy in a non-traditional setting where you don't have privacy, you don't have like an office sort of security and like the privacy of four walls. But she's very creative. She'll do therapy in the car or at the person's encampment. Like we've had people where we do the visit in their tent because it's really cold out and they have like a heating mechanism and go in the tent and just talk to them there because that's the most comfortable for them. So they don't have to come out. It's more comfortable for us. Sometimes we have visits at various public areas like the library. We can usually get a room from them to meet with people, or sometimes in the desk drop-in center, there's like upstairs offices we can take people if they want like a private session with us. So psychotherapy is one way that we kind of get creative to try to apply that. And then the group therapy I mentioned, doing that kind of intervention where we're doing groups in the community, whereas normally they happen in a clinic setting and people come at a certain time and are all in one clinic. But this is really about like making it accessible in the location of people that are primary people that need it. And then I guess I'll just mention like crisis services. We don't see a ton of like what you would call an emergency or crisis. That's usually the mobile crisis team or the Compass team, like you mentioned. But we do occasionally encounter people that are, in need of hospitalization or very unstable. And we really try to avoid using coercive measures. Our team is very much like on the person's own pace and prioritizing their autonomy. But it is rare, but it's possible for our team to encounter someone that needs hospitalization and needs treatment urgently in the way that we can't provide it right there, and we can't ensure their safety in that moment. So it is something that we have the capacity to do, but we really try to use that as a last resort when necessary.
Excellent. Yeah, about six more minutes, everyone. So let's jump in.
Yeah, okay. So I think that the social determinants of health somehow have to be connected with, I mean, it's obviously connected with systemic evil in our society. I think that as clergy, one of the things I think that we ask ourselves over and over again is how can we help? As in New Amsterdam, how can we help? And it just seems to me that one of the ways we can help is by bringing an awareness to the dangers of drugs. I mean, specifically fentanyl, which we don't know much about, and I'm hoping you can give us some insight in, because it just seems like it's become a real serious issue. And for us to go into the community and to talk to people about it, I don't think we really know enough about it. I don't know how it gets here. I don't know how it's made. I don't know how it's distributed. I don't know how young people, old people, that whole scenario, I think, needs to be more publicized. So even in your work, it seems to me that, and our work together, we ought to be able to have some kind of pamphlet that we can hand out in churches or in our community, in our schools, to just give people a heads up that, this is dangerous stuff, and you have to be careful. You need to really think about this. So do you have any comments about this fentanyl epidemic that we're going through that you could help us with?
Definitely. And I have some flyers actually that my colleague made that I can try to get to you about fentanyl and like awareness about it. So I'm glad you mentioned that. It's a really great venue to try to just dispense or disperse that kind of knowledge. So yeah, we've seen so many overdoses, and as you've heard on the news, fentanyl is just everywhere now. And usually like majority of the time it is what is responsible for the death in the overdose cases. It's a synthetically made drug. It's an opioid in the class of opioid, but much stronger than heroin, gives them some people are actually looking to use fentanyl because it provides like a stronger high than heroin does. And now it's been really just so prevalent. It's mixed in almost everyone's drugs. So like people that I ask, oh, do you want to test your drugs for fentanyl? Because we have these testing strips, so you'll know if you are getting fentanyl, if you're getting pure, whatever other drug you want. Unfortunately, everyone's saying that there's fentanyl in everything. It's not even worth testing it. So that's been really discouraging, because it's really hard to combat that when it's being used so frequently. One thing that we really advocate for is harm reduction, which is the sort of philosophy of making sure people are using safely. We can't always get people into treatment. They don't always want the treatment today, and Suboxone, methadone, or Vivitrol, but we can at least offer them Narcan, which is the overdose like reversal drug that can just be given by anyone. It's an inhaled drug through just a one squeeze inhaler that's very easy to administer if someone's unconscious. So we give that out very regularly to make sure everyone has it in their hands, so that if fentanyl was used, or if a mixture with fentanyl was used, that they can hopefully save the person's life. And people tell me all the time they use the Narcan to save their friend's life, and it's just scary how often that happens. And there are times when it doesn't work, and someone who's using alone, we always tell people never use alone, because then even if you have Narcan, no one can save you, no one can find you to know that you're not okay. So we really try to promote that, like the Narcan, and then not using alone. We also give out clean needles to people to make sure that they are using safely, not sharing infectious diseases with one another. And we do find that, like, even though it might sound as though we're promoting drug use, there's studies that show that people are more likely to actually get treatment when there's a harm reduction program involved, like a syringe service program. So, and we really believe in that model and kind of reducing the overdose deaths.
About 90 seconds, everyone. So I want to
that's
maximize
excellent.
the time.
Thank you. Yeah, get us those flyers so we can send them out.
Will do, definitely.
Dr. Lowe, you were involved with some policy recommendations for the city, particularly when we had the incident on the Green. Just wondered if those have been implemented, if you're involved with any additional discussions with the city from a policy standpoint.
Yeah, I guess I'm not probably directly involved anymore as much, but I would say there's been a lot of talk about kind of a coordinated response for overdoses, and that event on the Green in 2018 was just like really emblematic and sort of like a warning of like what could be coming, where all these people, like there were over 100 ED visits in that day of people using K2, which is not an opioid, but causes that particular strain caused very severe effects medically, and people had to go to the hospital. But that was kind of a warning. And then we realized like we need a more coordinated response. And since that time, there's been a lot of really great people from the city and other agencies working on overdose mapping. And actually we get alerts every week now of where have overdoses occurred throughout the city, and where are the hot spots, what are the trends. If there's like more than a certain number of overdoses, we get an alert that there's been a spike in overdoses this week. So just to keep a lookout and sort of be prepared for more massive overdoses or deaths. So that's been really, really helpful. I think it's still, there's still a ways to go in terms of working on this and tackling the crisis, but people have really come together to try to really make harm reduction available for people and be really on top of the numbers and the overdoses and finding out what's causing it. Now we can actually also know what drugs were involved in the overdoses, very like in a timely way.
Tremendous.
I know you got 20 seconds. I was thinking that our community health workers, our young ambassadors, maybe they could team up and you could walk them through one day what this journey looks like in the community. I think it would be helpful to them and the community for them to learn and get this hands-on experience. I'm just throwing that out.
Oh, very cool. Yeah, I'd love to speak with you about that more.
Dr. Lowe, thank you so much. Your passion is so clear. Reverend Clayton, Reverend Perry, always good to see you, gentlemen.
Listen, I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains. Haters swerving, cause they ain't ready for your final version. Whoa. I'm never gonna give up. Fall down, I just gotta get up, yeah. Cause this is my road. Let's camera